20 years. As far as the diabetic retinopathy screening camps are concerned, we have started since about 2005. By now, we must have conducted about 37 or 38 such camps. And organizing these camps, we have got a good support. In fact, it is the encouragement from Dr. P.N. Nagpal and also from the director, Dr. D.C. Mehta, MNJ Institute of Ophthalmology, Ahmedabad, Civil Hospital. So, what would be, because we know this problem, that's why we have taken up the activity of this NSPB, Panchmahal District Branch, Godhra. We usually conduct about 4 to 5 camps in a year. We can't conduct the camps usually in the rainy season. It is next to impossible. And we conduct these camps in a taluka places where, as we are told, that we are likely to get more patients. We advertise by publicity. We make publicity by pamphlets, by mic, and by writing by giving to the laboratory people, doctors, and also the persons who have examined the previous patients. We write the letters also. But as Dr. Narendra, somebody told this, it is difficult to get the patient, even in spite of doing so much publicity for nearly 1 month. We hardly get 100, 125 or 130 cases. Dr. Nagpal also visited twice for this camp. At that time, we got more than 150 cases each time. So I was just wondering to get the idea how to get more patients, because it becomes quite costly to conduct this camp.
Sir,
though we don't take.
May I interrupt you? What kind of equipment you use for screening?
We invite the retinal surgeons.
No, equipment.
That's what I'm telling you, sir. No.
Do you send retinal specialists for the camps?
No fundus camera, sir.
Okay, that's
what. This is the only way. We invite Dr. Nagpal Fellows, Dr. Rajesh Shiben from Baroda, and also the retinal surgeon from Ahmedabad. We don't have the fundus camera facility, but we do the PRP laser on the spot. But when there are certain patients who need focal laser, fundus camera, West injections, we refer these cases to the private eye surgeons or to the hospital. But
so that means, can we take that we are sending the retina specialists to the camps?
Yes, all sir.
Not the technicians.
No, not technicians. All retinal surgeons, all renowned.
Retina specialists, they themselves will go to the camps.
No, we invite them.
No. You invite you are sending the retina specialists to the base, to the camps.
Yes, to the camps.
Yes. That's what I want to know.
Yes,
that point. Yeah.
So we got 3 units. One from Ahmedabad, one from Dr. Nagpal, Civil Hospital, and one Dr. Rajeshri Vadani Arora, retinal surgeon from Baroda. And since last 4 or 5 camps, there are certain patients who need, say, Western, focal laser, fluorescein angiography. We take them at our own cost to these hospitals, and the doctors give concession. Even then, we don't charge anything from the patient. This is as a student, I just was learning from these talks how to increase this attendance. That's I was just wondering, because as compared to the cost, we get the less patient because we spend a lot of time and money and also a lot of man hours. But still, there are three objectives. One is to create awareness among the people, to take the patient at the same time, and to take the patient outside. So we give the lectures also, and about the diabetic, create the diabetic awareness. So
maybe you can involve local physicians, local diabetologists.
No, there is no special diabetologist, but we
local physicians, MD physicians, general practitioners.
But usually they
local IMA people, IMA doctors.
No, we always invite them or we inform them, but most of the time there is no cooperation from them.
Okay.
Unfortunately, it's everybody's opinion.
Yes,
then physicians are also not aware of this DR, and there is not much cooperation from them.
But as you said from your talk, we infer that you are sending the retina specialist to the camps. If the retina specialist is available, can spare his time to go to the camp, nothing to beat it. Number one.
Yes.
Thank you.
And so we invite them and we take their time.
Okay, as we invite, they come. Basically, we are sending them for the camp. Thank you.
Yes. And as I told earlier, Dr. Nagpal has so he is his main support.
The other model, what we are doing is we are sending the equipment and technician, retina specialist will sit in the base also. Thank you.
Thank you, sir.
Any other?
Ahmedabad.
Okay.
To create awareness about diabetic retinopathy, we started contacting general physician, MD physician who are doing practice in and around my practicing area.
Yes.
And sorry to say, sir, but I found most of them were not very much aware of the dire consequences of diabetic retinopathy.
What I'm saying.
What I tried to do was I made a small PowerPoint presentation in local language so that I can show it to the staff of the physicians, so they should also get aware of this thing, and because they are the people who are constantly in touch with the patients rather than the physician himself. I have successfully conducted 3 camps with different physicians in my area.
Okay.
And the first problem was, as sir rightly said, that physicians were so busy in their practice that they were not able to spend enough time for it. So now we have changed our pattern. Instead of calling the patient to my hospital or my facility, we as a team go to physician's place. We get the patients who are there on one particular day, who are there on their OPD, or they are called in their OPD.
That's right.
We screen them with 20D.
Nowadays it's working more.
Yeah, and since last 3 or 4 camps, I am getting good results.
Nowadays that's the reason why most of the diabetologists in urban centers, they are having the fundus camera in the clinics, diabetology clinics. And with the weekly once, our technician will go there, take on the patients, transmit to our hospital, we treat them, we advise them, that give more results, more practical results. Thank you.
I created 2 projects, phase 1, one project with phase 1 and phase 2 with the AIOC Association, and 100 patients. Actually what we did, we have a charity OPD. So we screened patients from our charity OPD, and we screened patients, poor patients, from our private OPDs also, because sometimes private patients, poor patients come in private OPDs who cannot afford Avastin and lasers and all. So we created 100 patients in phase 1 and 100 patients in phase 2 also. So with one Avastin you can give 25 patients.
Yes.
So the ISYs donated us Avastin vials, and we treated them with Avastin injections, and we did lasers. And that way, even if you don't have projects, from your own private OPD you can screen poor patients, and then you can screen from your charity OPD.
Individual practice, that's what I mean to say, yeah.
Yes, and if somebody donates a Avastin vial and somebody comes to become your partner, you can partially sponsor and partially that person can sponsor. And this way, even without a project, you can do it.
That's what I meant when I said in the beginning, people are after the advent of Avastin, medical retina income has gone up tenfold.
No, there is an inadvertent use of Avastins. That is material. Let us not go into that.
I'm just telling you later way.
What Naresh wants is that when we are screening or some project is coming, it is like UK experience.
Yes.
They have a national health scheme under which every citizen will come. We don't have that. Unfortunate for India.
What do you mean to say that is the basics,
actually.
We without project, without group, individuals can also do it, this diabetic retinopathy screening program. That's what I mean to say, Dr.
Yes.
But sir, what is the role
Please.
of NPCB?
Sorry?
What is the role of NPCB
Yeah.
for continuing?
Very valid question. I will answer you. Nowadays in the NPC program, for each laser we are getting 1,000 rupees.
But number of what happens?
But when NPC computer, with the NCPV, you have to do a lot of paperwork.
Yes, right. You are 100% right.
Surgery.
You have to have fundus photo, you have to have pre-laser photo, post-laser photo, patient photo, patient name.
Lot of documentation. They need
No.
lot of documentation.
They are not giving anything for the camps.
Sorry, madam.
NPCB is giving money only for the laser.
Yes.
But not for the camps.
Not for the camps.
And even for that,
The basic thing is more important.
for NPCB,
That is not within my purview.
Sorry, I will tell you one thing. It is better to have support from other NGOs rather than NPCB, because if some doctor is really good and very busy in his private practice and really wants to do some philanthropy, it is very difficult to follow NPCB, because NPCB people will have this document, that document, too much paperwork, and
That's what I said, madam. That's what I quoted Mother
Taking
Teresa.
1,000 but is safe is not worth taking.
See, this community,
comes and helps.
in this diabetes screening program can be done individual doctors also.
Yeah.
That's what I try to assure the local level.
There is no.
This is what the bleb should look like. But of course, you have all kinds of blebs that you see. In the best of hands, these are the variety of blebs that you go on seeing. The long-term success of procedure, therefore, depends on the functioning of the bleb. Scarring can close the filter and lead to a failed bleb. Scarring basically happens at various sites: the conjunctiva, the episcleral tissue, the scleral flap, and the ostium. And this is what a scarred bleb actually looks like. To enhance our chances of success, therefore, it is imperative that we are able to identify scarring early and treat it accordingly. Identifying bleb morphology in the early post-op period predicts the long-term success of the bleb. Hence, looking at the blebs critically in the early post-op period forms a critical part of the treatment protocol. Everyone is envious of seeing an envious bleb which is adequately vascularized with multiple microcysts, low height and low encapsulation, as this will predict a definite success in terms of a functioning filter for years to come. After years of practice, it is still difficult to replicate a trabeculectomy in every patient. The most successful surgeons over the years have not yet been able to give predictable results post-trabeculectomy, unlike cataract surgeons. However, all the masters have been able to shepherd their blebs from time to time post-operatively to enhance the results of their trabeculectomy. We are going to discuss various modalities that can be used to salvage failing blebs, and we shall, at the end of this instruction course, be well armed to do trabeculectomies with far more confidence. This entire collage of pictures actually tells you how many things you've got to do when you're shepherding your bleb. The various phases that one goes through when shepherding the bleb, as you rightly know, starts even before you do the procedure. That is, selecting the correct patient, ensuring that you have created the ideal circumstances before operating. For example, make sure the preoperative IOP is low by whatever means. Make sure the patient is not on anticoagulant therapy. Put the patient on some topical steroids for a fortnight before surgery if the patient has been on long-term medications. As the pre-op considerations are beyond the scope of this instruction course, we shall not discuss all of these in detail. So also, proper technique during surgery is equally important, but that needs an IC by itself. We shall be concentrating on what happens thereafter. That means from post-op day 1. Yes, it literally means looking at the eye in details from post-op day 1. Immediately on day 1, you'll get to see the formation of the bleb, the anterior chamber reaction, the tightness of the flap, a well-formed bleb which is sealed well, and of course the intraocular pressure. The findings from then on lead you to predict the kind of filter you're going to be left with. These are all the kinds of things that you might see on the first post-op day. Don't be worried. You're still going to go ahead and have a successful trabeculectomy. A shallow anterior chamber with low intraocular pressures may point to a leak. A shallow AC with a high intraocular pressure cautions you to think of an aqueous misdirection. A well-formed AC with low pressures tells you to look for choroidals and overfiltering bleb. And one with high pressures tells you to look at the ostium or a block, which could even mean tight sutures. From now on, we will be looking at how to look for bleb morphology in the early stages that will predict the future of the bleb. When we talk of bleb morphology, there are a number of attributes we have to consider. The bleb height, the vascularity, the extent, the microcysts. But I'm not going to take too much time. I have an array of distinguished glauconologists who will be talking in my instruction course. So we'll start with Dr. Manish Shah, a well-known figure in glaucoma circles for well over a decade now. He will discuss early post-op bleb evaluation. I'll just finish all the introductions to my speakers so that I don't keep coming back to the dais. He will be followed by Dr. Mayuri Kamar, who will be talking on only identifying late failure. Then we have Dr. Sushmita Kaushik, who will be dealing with needling of blebs. When will you resort to it and how? Use of antimetabolites in bleb needlings. Dr. Sunil Jain will then take us on to encapsulated blebs. Dr. Rajul Parikh, who is to talk on thin avascular blebs, is unfortunately down with dengue and unable to make it, but we shall cover his topic in the panel discussion. Dr. Deepak Edward, who had promised to make it, was to talk on blebitis, but this topic too has been left uncovered, so I shall follow on with a panel discussion, which will start with interesting cases showcasing infections that loom large that all of you face in practice, and of course a whole lot of other problems to deal with blebs. This should be an interactive session. Not only will my panelists tell you what they would do in the situation, but I would like all of you to also tell us your experiences, share your experiences, and question the panelists for whatever problems you see necessary. Thank you very much. Dr. Manish, please.
Thank you, Rita. Is this on? Thank you, Rita, for inviting me to participate in this lovely instruction course. And as you have pointed out, I will be talking on the evaluation of the bleb in the early postoperative period. The aim of the early evaluation is to detect problems in the earlier stage, allows you the opportunity to modify the healing response and get a desirable outcome and avoid complications. So if you are watchful and act at the right time, as at the end of this course you will probably be informed enough to do. What are the factors that you are going to look at when the patient comes, especially from the bleb point of view? So as Rita pointed out, you are going to look at the bleb elevation, means how much it is raised, the area which is covered by the bleb, the vascular response which keeps changing, especially in the first few days and weeks after the surgery. Looking for bleb leaks, especially in the early postoperative period, are very important. Then checking other things like the intraocular pressure, anterior chamber reaction, depth, and all those things, and other factors. But I am going to concentrate mainly on the bleb in the postoperative period. Bleb elevation, the first factor which we are going to talk about. Ideally, when you finish your surgery, bleb should be well elevated on the table itself, and you can achieve this by a paracentesis incision. You inflate, you inject some amount of BSS, and you can see your filtration and your bleb gets elevated. In the post-operative period, if things are going well, it should remain elevated all throughout. If the bleb is elevated initially and starts going down, that is a sign that there is poor filtration, less fluid is filtering out, probably due to tight sutures or something blocking the bleb, and sometimes due to a leaking bleb. So these are some photographs of how we are going to evaluate. You are going to ask the patient to look down, and you are going to see with a wide beam and also with a narrow beam and try to see the curvature. Sometimes it is difficult on slides to show you because we are not getting 3D, but when you look in on a slit lamp, you can easily identify the level, the amount the bleb is elevated in the post-operative period. And as I said, this should be on your eye all the time. If you see your bleb becoming shallower or flatter, especially in the first 2 to 3 weeks, you take it as a sign that either the sutures are too tight, or there is something blocking, or there is a leak. And if you take care, then you will not get this outcome where the bleb is totally flat, nothing is filtering, vascular response is not much, there is no leak. This is because in the earlier stage you did not check enough whether there is proper filtration or not. Sometimes you can give some amount of digital pressure on the eye gently and see the fluid egress, and you can actually see the bleb getting elevated a little more, especially if you are not satisfied with the elevation. The very important step is to look for bleb leaks, and we should look at these bleb leaks at all times, at every visit of the patient. First of all, you should not get a bleb leak. If you are meticulous in handling your conjunctiva, taking watertight sutures or using round body needles which leave smaller tracts, and checking for leaks by the Siddle's test is very important. As I have seen, lot of people don't do the Siddle's test in the proper way, so I have made a small video of the Siddle's test, and the way to do it is to put on the blue filter with a very wide beam and put anesthetic agent into the eye, and then take your fluorescein strip and paint on the bleb. I have seen people doing Siddle's test by taking the patient and putting fluorescein before and then trying to look. You will not be able to pick up the fine leaks. If you do it this way, as you can see, small, maybe this is too dark over here, but anyway, you can do it in your clinic. The way to do it is to paint it with the fluorescein strip, so that the moment the fluid comes out, it dilutes the fluorescein, and immediately orange fluorescein becomes green, and you can identify the point, the amount, everything very well. Very few people are going to miss leaks like this, where from everywhere the fluid is pouring out. So we want to identify smaller leaks and smaller punctures also. In the early phase, first 7 to 10 days, there may be a lot of congestion. So when you are looking for a vascular response, you may not be very easily be able to judge it because of the pre-operative drugs, the post-operative drugs, and the betadine that you have used. The eye becomes a little congested. So as you can see in this photograph, everything looks angry red and it's difficult to see the vascular response. As time goes by, with the steroid you have used, most of the eye will become quiet, and that is the time when you can really start judging the vascular response. So some congestion will still be there in the bleb area. An ideal bleb should start appearing where the vascularity looks almost normal to the rest of the conjunctiva. If there is a little bit of congestion, that also should eventually start becoming less. And you can pick up if there is excessive vascular response in about 10 to 12 days time, where large blood vessels start appearing on the bleb. They grow towards the bleb, and you will see corkscrew kind of vessels growing onto the bleb. As you can see in these photographs, you can see these really large blood vessels. As you can see in other parts of the eye, the blood vessels are not so big. Only in the bleb area, these huge blood vessels, some growing from the side, some growing from behind. Usually they come from behind. And you can see that this is the thing. Actually, this is a very late photograph. You could have identified this maybe a week or 10 days earlier than this photograph. And you can see a lot of congestion behind the bleb, where you have taken sutures. Later, you start getting avascularity, especially if you have used the antimitotic agents, and you will start getting avascular thin blebs and encapsulated blebs and a ring of steel. You can see these photographs. These are 4 months apart, and you can see here the central bleb area is quite pale, but there is a lot of angry vessels around, and this is the sign that there is scar tissue. You can act over here, but what is going to happen if you don't act is that this area will shrink, and you will get more and more scar tissue growing in, and this is how slowly your whole bleb is going to scar up. You will get this ring of steel in some cases where you get a lot of fibrosis at all the edges behind the bleb area. So you can see central bleb area avascular, the conjunctiva is okay, it's a little on the thinner side, but you can see all this white tissue at the edge, and after that you see these big blood vessels which are there around. So this is the formation of what we call a ring of steel, or a large scar tissue at the periphery of the bleb. And this is what we call bleb encapsulation, when the whole bleb gets walled off from the rest of the subconjunctival tissue, so it becomes an actually isolated extension of the anterior chamber. So this is what happens, very very thick tissue all around, so no fluid from this bleb is going to drain anywhere out, then you will get high pressures as well. The typical response that you see if you have shepherded it well is you will get a mixed morphology bleb with the central area which is thin walled, avascular, cystic, and you will see that this is the central area, but you will see a much larger, diffuse, wider area of conjunctival elevation, which you will be able to see only if you put the slit lamp at an angle and make a fine beam and see that actually there is elevation even here and there is normal vascularity. Microcysts are because of transconjunctival filtration, they are a proof of good flow, they are a desirable thing, they are seen at high magnification, as I told earlier. With a bright light you have to put it on oblique illumination, and you will be able to see in retro illumination small soap bubble kind of microcysts in the conjunctiva, and they mean that there is very good transconjunctival filtration. IOP generally will be related to the bleb elevation, and anterior chamber shallowing may be due to overfiltration in very large and very highly elevated blebs, or due to leaking but low blebs. You can also evaluate blebs. This is just to tell you that ASOCT, there are enough papers to talk about ASOCT used in evaluation of the bleb morphology, but we are today talking about clinical evaluation, so I have just kept the slide. After you evaluated, there are methods to grade your bleb. And this is the Indiana Bleb Appearance Grading System, IBAGS, which considers all these parameters: the height of the bleb, the extent of the bleb, the vascularity of the bleb, and the Siedel's test outcome. You have to write it in this format. HEVS are the short forms or the symbols for these things, and you have to grade each of these from 0 to 4, where 0 is flat and 4 is very high. Extent is 0 to 3 in clock hours. Vascularity is also graded from 0 to 4, none to heavy. And Siegel's test is graded as 0, no leak, 1 is very small pinpoint leak, and 2 is a full-blown leak. More popular is the Moofield's bleb grading system, or MBGS, in which you have the height is classified, the area of the bleb is again subclassified as central area and the maximal area. That is 1A, 1B. The height of the bleb is, the symbol is 2, and that is graded up to 4. Vascularity, again, central vascularity and peripheral vascularity. As I showed you in the photographs, as the bleb becomes older, there is very often different kind of vascularity over the bleb itself and the surrounding tissue. So that is 3B and 3C. 3A and 3B, that is graded from 1 to 5, and this is non-bleb vascularity, means how much congestion is there on the eye otherwise. So that is 3C. And presence of subconjunctival hemorrhage is also graded. That is present or absent. In this, there is no grading of Siegel's test, and if you want, you can add that over there as well. So these are some examples of how you can grade, and as you can grade over here, this is the bleb area, and central area, peripheral area, height. So you can grade it here. The central area is about this much, which is equivalent to about 1 to 2 clock hours. So that is graded as 2. 1B is the full area. That is quite diffuse because there is filtration here and here as well, which is going up to 3 clock hours. So I graded it as 3. The height is just average, so I graded it as 2. Then 3A, 3B and 3C are all vascularity, and as you can see, the central vascularity over the bleb in this photograph is very high. Therefore 3A I have graded as 4. Peripheral vascularity around the bleb is also high, but less than what is there right on the bleb, so that is 3. And general vascularity of the eye is average, so I have graded it as 1. There is no subconjunctival hemorrhage, so that is graded as 0. So in this way you can grade, and this kind of grading given to the bleb will help you in following your own case as well as to report in studies or which you are doing. This is another picture where you can see this is the central area, and you can see and peripheral area. So here I have graded the 1A is the central area, which is quite big. As you can see, it is extending from here to here. It is 3 clock hours. So I put it as 1A is 3. 1B is the peripheral bleb area, which is not that big actually, so I have graded it as 2. The height of the bleb is pretty high here, so I have put it as 3. Then you can see the vascularity. 3A central vascularity is completely pale, so I put it as 0. The peripheral vascularity is very high, so I put it as 3. And the general vascularity of the eye, which you can't see in this photograph, but it is not totally quiet, so I put it as 2, and no subconjunctival hemorrhage. And this is a kind of a bleb which you would desire to have. A large bleb area, which is 4. Peripheral bleb area is also quite large, that is 3. And you can see the height is pretty good, that is 3 again. And central vascularity is 0. The peripheral vascularity is not very congested, it is 2. And general eye vascularity is 1, and no subconjunctival hemorrhage. So this is just few examples on how these grading systems can be used and to record your grade. And after you have seen these changes, what we can do and what we should do at what stage, I think other speakers are going to bring out more in detail. Thank you.
Thank you, Manish. Thank you, Manish. That was a very lucid presentation on early post-op bleb evaluation. And I'm sure when you are into doing tuberculectomies, you'll realize how looking at the bleb as in detail, as Dr. Manish just pointed out to you, you will definitely be able to make a difference to your results post-operatively. With this now, can I call on Dr. Mayuri Kamar? She will be talking to us on evaluation of late failing blebs. We'll first talk about evaluating the blebs, and then we'll talk about treating those blebs in their respective phases. So Dr. Mayuri Kamar, as you all know, has been practicing glaucoma for a very long time in Ahmedabad. And it's a pleasure to have her to share her opinion with us.
Thank you, Rita, for giving me this opportunity. I'm going to talk only on the identification and not the management part of late bleb failures. No financial interest. These are the blebs which you always aim for or dream for. So trabeculectomy is the most widely used surgical procedure for glaucoma, and in spite of use of antimetabolites, we still see the lot of cases of failure, and at the end of 5 years, almost 50% fails. So identifying a late black failure is also a very important topic. Now, what is the definition of failed black? It's defined as a loss of glaucoma control with or without supplemental medication at some point in the post-operative period. Early black failure usually it's arbitrary. It can be within 6 weeks of the post-op, and later on you can call it as a late black failure. Now, in identification, I have put up 3 steps. First, you have to suspect that this is a patient who is likely to fail. Then evaluate the bleb and then confirm your diagnosis. And this is a list of risk factors. These are the patients who are likely to fail whatever you do. So keep an open eye and suspect. Do more follow-ups in these patients, like young patients, previous surgery which is already been failed, or some retinal surgery has been done, bad conjunctiva, or patient is using multiple topical drugs for a longer time. So this conjunctiva is not healthy. So many patients are listed here should be suspected for the late black failure. And evaluation, believe me, late black failures, the only correct sign is the intraocular pressure. So serial evaluation of intraocular pressure which is showing rising titer or rising trend should be suspected as a late black failure. The slit lamp examination is being said in detail, but these are the points usually we look for. And for me, gonioscopy is also a very important tool. By and large, the late black failure is because of the increased vascularization and lot of fibroblastic activity in the subconjunctival as well as in the episcleral space. And rarely it could be because of the obstruction of the internal ostium, because of the synovial tissue or fibril material in the ostium. So before you do anything, please do gonioscopy, and these are the classic example. You can see the uveal tissue, the process coming in and blocking the window. Here the iris pillar has come up and blocked the window. So if you can identify this, you can manipulate and do something else for this. Now slit lamp evaluation, whatever classification is been described, it gives you a subjective finding. But how can you do a better evaluation? First is have a diffuse light, and overall appearance of black should be noted, and then have a thin oblique light slit which will give you the transparency of the conjunctiva. It will also give you the depth of the penetration and what is happening underneath. Though very difficult, but sometimes we can manage, and look for some microcystic changes also in the area of the bleb. The morphil classification requires the photo slit lamp, and you have to keep this whole chart near to your slit lamp, and this has to be compared with your own findings. So this becomes a subjective. IBEX, as Dr. Manisha said, includes the Seidel test, so whatever is convenient to you, you can use it. But whatever is seen here, usually this is good for the early black failures. In late black failures, usually this is not seen. And the limitations of slit lamp evaluation is shown here. See, this is also very good high elevated black with the pseudopodias here, and this is also one of the avascular highly elevated black, but this is not a functioning black. So we don't know what is going on internally. The late black failures is because of the internal morphology change. So a clue to the late black failure, first as I said, is always a gradual increase in intraocular pressure, change in the bleb appearance, relatively it becomes avascular, non-transparent and diffuse or almost flat. I don't think vascularity plays much role in the identification. Now this is a case where it is a successful black, IOP well on the target without any medication. 18 months follow-up is shown, 2 months, 3 months, you can have a good elevation, slit lamp examination with the slit, a small microcyst at 6 months, gradually some pigments came and disappeared also. Still elevation is persistent and good vascularity, pseudopodias, everything is fine in this case. Now this is another case, 1 year follow-up, lot of vascularity here to start with at 2 months, but the elevation is good. The area occupied is almost 2 o'clock. What is happening here? Now see the gradual change in the transparency of the bleb. The color of the bleb is also becoming white, opalescent in this area, becoming flatter and flatter, and gradually this was a non-functioning bleb. Alternatively, an elevated and large blebs like this can be there, which is an encapsulated bleb, and I will not be discussing this wall of fibroblastic ring. It has already been done by the previous speaker. So clinically, essentially clinically good looking bleb like this may not have a good bleb function like in this case. And why it is so? Because as I said, there is a limitation with the slit lamp examination, internal morphology cannot be seen. So in these cases, maybe using an imaging technique will guide you what is happening underneath. Like this is the bleb, and you can see a beautiful hyperreflective area, spongy look, subconjunctival separation and multicystic block. While here hyperdensity echoes with a very thick bleb wall, which is a sign of a failure. So imaging can be utilized in late bleb failure. You can use ventral segment OCT or UBM, and this is how it has been described. You can see the subconjunctival fluids fill space of a hyperreflective area or variable reflectivity in this wall. And then there is a scleral flap. You can see the ostium here with the suprascleral fluid spaces. And this bleb wall can be classified into bleb wall reflectivity and bleb wall pattern. Look for the hyperreflective areas and root beneath the scleral flap. And this is a classic example of bleb wall reflectivity, which is uniform in nature. Here you can have a multiform reflectivity areas with a small pockets of the aqueous underneath. And this multiform reflectivity wall can have 3 patterns, and one bleb can have all 3 patterns. Like this is a bleb wall with a multiple internal layers. Here subconjunctival separation and a spongy loop and large cystic space here. And this was a multicystic bleb. And of all, the multicystic bleb found to be long-lasting in one of our study. This is a failed bleb showing you the hyperreflectivity or dense area of the fibroblastic activity here, though the root beneath is patterned and have a small aqueous pocket here. This has been already shown multiloculated cystic bleb with a small and large cyst with a spongy look, but these blebs are of a high risk variety where the blebitis is a frequent occurrence. And this is an encapsulated bleb showing a very thick wall, which is showing you a boundary here. And this is a failed bleb or flattened bleb with no bleb elevation and high scleral reflectivity. So evaluation of failing bleb on OCT can guide us about which bleb is likely to fail in the future. And uniform reflectivity is a sign of failing bleb. Now this is another case where at the 6 weeks you have a beautiful bleb underneath. You can see the subconjunctival separation, large cyst, multiple microcysts. But what happened on this bleb? After 12 weeks the elevation is still same, though there is a change in the transparency, and here you can see the lot of fibroblastic activity going on in this area. And at the end of 12 months there is absolutely flat bleb with no hyporeflectivity areas. Another case where at the 6 months with a good follow-up and good IOP control, at 3 months the same bleb became flat with hypervascularity. The IOP went up to 36. We did the needling, and after needling you can see change in the pattern of the bleb wall. So identifying a late bleb failure, still I believe IOP is the most important parameter. Never forget to do gonioscopy to see what is happening in the inner fistula, and anterior segment OCT or UBM can be a good adjunct to your clinical judgment, and you have a scope for the early intervention. Thank you very much.
Thank you, Mayuri. Well, Mayuri spoke quite well on identifying late bleb failure, and let me tell all of you that I don't think all of us have access to an ASOCT, which does not mean therefore that you can't identify a late bleb failure, because she has time and again stressed on the fact that please look at the intraocular pressure, Smita Kaushik, and she will now be dealing with encapsulated blebs. What do you do? Thank you.
Okay. Thank you, Dr. Rita, and thanks for that introduction. Everybody is very kind to me in the GSI, and I'm very, very fortunate for that. Well, good afternoon. We'll now talk of bleb needling after we've discussed how to identify early and late failures. And we'll just do an overview of when we resort to it and how, and the use of antimetabolites. There are no financial disclosures to this talk. So we'll look at bleb failure. When would we resort to needling? The characteristics, clinical evaluation, and additional, most of it has been done, but I'll just stick to some points to keep in mind before doing a needling, because there are other things that you can do when the bleb fails. Then we'll see a little bit about the procedure and the adjuncts that we can use. So as Dr. Mayuri time and again reiterated, the failure could be because of an intraocular process, so you need to look at your sclerostomies. It could be intrascleral, which means the scleral flap has sort of flattened, and it could be subconjunctival, which could be due to episcleral and tenon-conjunctival interface. So common sense tells us that it's only in the third one that doing a subtenons needling would help. If you have a blockage intraocular or you have a blockage in the sclera, then just needling a subconjunctival space is not going to happen or work. And that's the reason why you've got to evaluate these blebs and decide on which are the cases which require needling. And how does it work? It works by disrupting the subconjunctival fibrosis and restoring the bleb space. So this method of re-establishing filtration have very variable results. And I suspect we have variable results because these blebs were needled regardless of what the cause was. And that's why we have reports, and I've just put them down, from 91% success with a mean follow-up of 9 months to 80% after an average of 2.5 needlings. So an average of 2.6 needle revisions and a success rate of 59% when you looked at them a year later. So why are they so variable? Because intrableb morphology is so difficult to assess clinically. So you don't really know, as Dr. Mayuri said, what's happening underneath what you're seeing on the sclera. And it's essentially a blind procedure, and more importantly, the status of filtration under the scleral flap is not known. So if you're going to needle just under the surface of the conjunctiva, it's going to be a little difficult. So this was what we did, and it's funny to say almost 20 years ago. It's been so long since we did our PGs, but type 1, 2, 3 and 4, despite all the new classifications that has come, this is, I find, the easiest clinically. So it's just, if you remember that a type 1 and 2 bleb are functional and type 3 and 4 blebs are non-functional. So this is a typical example of a thin polycystic bleb, a flat, diffuse, relatively avascular. This is a prototype trap. If you get a bleb like this, you're done. There's nothing else that you need to do. But this, as all us glaucoma surgeons know, is many times when we get very, very lucky. A type 3 is a flat appearing bleb with subconjunctival fibrosis and engorged vessels on the surface, and type 4 is an encapsulated bleb, which is here. It's localized, dome-shaped, hypertrophied, and the type 3 and 4 do not function, and the type 1 and 2 function. So just take a bit to look at these blebs and put them in your head that if you see morphological blebs like the first two, they're likely to be functional, and the last two are likely to be not. So, to ensure that your needling has a good procedure or a good result, that's best is to do it in a type 3 bleb. And it's obvious, a type 3 bleb will be the one which will be amenable to a subconjunctival disruption of tissue. If you're going to try that in a tenon cyst, you're not going to be able to needle and not going to be able to do much. The second thing you need to be very, very careful about is that it has to be an open sclerostomy. I would talk about the UBM because I have access to it, yes, but one very good clue is to see that the internal ostium is fish mouthing. And what I mean by that is, look at it, if it's a little open, like a fish mouth, it's likely that there is aqueous percolating. But if on gonioscopy, even if it is not blocked by the iris or uvea, if it is closed flat, then it's most likely that there is no aqueous flowing into that scleral flap. And if there's no aqueous getting out of the eye into the scleral flap, unless you raise that scleral flap during your needling, which has also been described, it's not going to work. So be very careful in your clinical examination, and these are all examples of fish mouthing. This is a large fish mouth. You can be sure that this needling is going to work. This is another one, and this is another one. So if your internal sclerostomies are open and the fish mouth, it's a good clue that probably your needles are going to work. It's unlikely to work in a tenon cyst if you have a blocked sclerostomy and in a hypertensive phase. We'll just touch upon a hypertensive phase at about 6 weeks of time. Usually, this is too much of a good thing. Too much of aqueous goes out of the eye. The microcysts underneath the conjunctiva flatten out, they don't leave the eye, and the bleb gets bigger and bigger. It's important at 6 weeks to recognize a hypertensive phase, because contrary to what is taught, all you need to do is reduce aqueous production. You give them aqueous suppressants for 2 to 3 weeks and the bleb settles down, and you could avoid landing into a tenon cyst. But those are all careful procedures and careful observations of the bleb. So can we look inside? I don't have the ASOCT as yet, but we have tried to look inside using the UBM, and we just tried to look at the structure inside of filtrant bleb. The most important thing that we realize is if this route is patent, because I don't like to blindly go under the scleral flap and enter the eye with the needling procedure alone. So we basically do a subconjunctival needling, and if this scleral route is occluded, then the needling is definitely not going to work. So the UBM classification of blebs have been there for a long time now. So these are just what Yamamoto's group has described. But more than the blebs, what we at PGI look at is, like I said, whether the scleral root is patent or the scleral root is occluded, and that's the only one thing that we look at. Because once we decide that it's a fibrous bleb which is not working, it doesn't really matter how many microcysts there are in the bleb or whether or not there are too many of them. So to summarize this, all that we did was we took all our type 3 blebs and we did a UBM in all of them and needled all of them just to see knowing whether or not the scleral root was occluded or patent made any difference to the result. And the presence of fluid under the scleral flap, as common sense we thought, did correlate with success. So this is just a quick 1-minute video of what we do. We like to do it under the microscope because I think it's more controlled and the patient is under anesthesia and lying flat. The slit lamp can get to be very traumatic. It's very difficult for a patient to keep looking down when somebody is poking a needle in the superior part of his eye. So we do it. This is the type 3 fibrous bleb that I showed you. We enter away from the bleb so that there is no leakage later. And then you can see I use a 26 gauge needle. It has been described with a 27 and 28. But what I've noticed is many times that gets to be too thin and malleable, and many times it doesn't give you enough purchase to cut the scleral tissue. With the bevel of the needle up, the sharp edges just cuts through the subconjunctival fibrosis. And in the OT, you can actually hear it go kadak, 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 kadak. So this is what I tell the PGs, can you hear that? So if they stop talking and chatting, they can hear. You can hear the fibrous capsule really be excised. So now if you see this slowly, you see this is getting more transparent and the fluid is started to percolate out. So you can actually see the fluid coming out into a bleb. Can you see it? It raised a little bit. So you know that you're going all right. But remember this, we've ensured on the gonioscopy that the sclerostomy not only is open, but it's also fish mouthing. So we're sure that there is fluid under the scleral flap and we don't want it. I don't like this bleeding, but somehow it is inevitable when you needle, because when you're disrupting scar tissue, it does tend to bleed. But at times you just have to live with that. So you just carry on. There's no rocket science to this procedure. You just carry on, and it takes a lot of patience. It's very annoying to just keep fiddling under the conjunctiva, waiting until the bleb forms. But that is the end point really. You need to wait until the bleb forms, and the globe does soften, and you know that you've restored filtration, and then you go ahead. So this is the end point, and this is the same patient. Post needling, you can see the fluid here. So you know that, and this is what he was like with a patent scleral root and absolutely hyper reflective. The first few things are coming, and here at the end of 3 weeks you have a nice big cyst there. So you know that you've restored filtration. Where there is the scleral root is occluded, this is an example where it was absolutely occluded. We did the needling 1 month, 6 months, it has made no difference whatsoever to the bleb, commonsensically, because there was no fluid that was going out of the eye in the first place. So blebs with scleral root patent on UBM appear to have more chance of success. What about antimetabolites? I'll just wind up with this. Always at the end of procedure and away from the bleb area. This is where I usually inject it. Way off so that it percolates diffusely. Be very careful at the end of the procedure. Remember, you have a soft globe. You've restored filtration. If you're going to put it in the bleb area, you're going to be in a lot of trouble. The dose that I use is 5 milligram and 0.1 cc. It's the easiest thing on earth because flyfluorouracil is available in this percentage. It's available as 250 milligram and 5 cc, so that's 50 milligram per cc. So you just take 0.1 of that and you're in. You don't need to do any dilution. You don't need to do anything at all. But be careful. And I put this case up, and this is a stupid thing that I did once, but this is on the slit lamp where I've injected 5-FU in a patient with low pressure and after a suture removal. And this is what happened immediately. It went absolutely white in the center, and this is what happened to the cornea. I was sure he would be landing up with a PK. 1 week later he had this horrible epithelial defect, and this is what his cornea looked like. And maybe a month later it had started clearing. We had our hands in our mouth, so to say, but finally 6 weeks later he did clear. This is what he was like. This is what he started off with at the end of the procedure. So you do get your heart attacks. But in case your 5-FU does go in and you recognize it has gone in, just come out and just hold on. There's no need to panic. They do clear. Thankfully, in this case, it did. So to summarize, a clinical evaluation before taking a decision to needle or revise a bleb is mandatory. Judicious patient selection may hold the key to the success procedure, and UBM may be a useful tool in this decision making to avoid unnecessary needling. Thank you.
Thank you, Sushmita. And she's actually taken us through the process of needling. But who doesn't land up with the problem? As long as you know how to tackle the problem. When I had this problem, I know I called up every conceivable glaucoma consultant that I knew, and nobody knew what to do. But eventually we read up and we found out, and not that I haven't had it again. I've had a couple of occasions again when I've had 5-FU into the eye. But having washed it after the paracentesis, we've done extremely well. So don't be scared. From here on, we will now go on to encapsulated blebs, because needling is not the end of the story. Many times you will land up. Yeah, Kirti.
Actually, our experience in our center for the last 15 years now, I've been using routinely 5-FU needling in a virgin. Somehow in our patients, plain needling doesn't work. So, touch wood, we have.
The goal of trabeculectomy, as we all know, is the long-term intraocular pressure reduction. But however, it does not end with the surgery. The post-operative management is actually critical to the outcome and is more challenging to do than the procedure itself. Now, this is in brief what Manish had initially discussed, but I'll be restricting myself to the high intraocular pressure, what can be seen sometimes in post-operative patients after a good trap. Now, whenever you have a patient where the pressure rises post-trabeculectomy, you have to look at two things, the bleb appearance and the anterior chamber. Now, when you look at the bleb appearance, you could have a low bleb or a high bleb. Now, if you have a low bleb, that indicates that the aqueous is not coming out through the ostium into the subconjunctival space, and there is something wrong inside the eye. So it could have, because of the external factors like what has been described, the too tight sutures or subconjunctival fibrosis or internal sclerostomy obstruction. Now, if you have a high bleb where the aqueous is coming into the subconjunctival space, that indicates it's a Tenon's cyst. Coming to the next differential diagnosis, you also look at the anterior chamber depth when you have a high intraocular pressure. Now, again, depending on the phase, the post-operative phase, when the patient presents to you with a high intraocular pressure, if he presents immediately to you following your trap, that is within the first week, the most likely diagnosis is either tight sutures or internal ostium obstruction. If the patient presents after a few weeks, probably a couple of weeks, it's most likely a Tenon's cyst. and after 4 weeks, as Dr. Mayuri described, a late bleb failure. Now coming to my topic on renal cyst or encapsulated bleb, it can occur even when you use antimetabolites, though it has been described in the earlier phase, but it can occur when you use antimetabolites too. Now the clinical features, usually when you look at the bleb, it's an elevated and a very localized bleb, the pressures are high, the anterior chamber is deep, and you have to do a gonioscopy always just to rule out any obstruction, less likely in these cases to rule out an internal obstruction. This is just the incidence of all the past studies and varies anything from 3.5 to about 30% in the studies as such. Now what are the risk factors? What are the increased incidence, how this bleb encapsulation can occur? Younger the age, as we all know, have more thick tenons, so most likely to develop a tenon cyst. Male gender has been described. In the past they said when AIT was performed, those patients were more likely to develop encysted blebs. And one more important thing which I would personally like to highlight is the glove powder. So I always wash my gloves after I drape and all, so that the powder gets washed up, or you can use powder-free gloves. Because in my personal experience, I had a series of encysted bleb, and following this precaution, it reduced considerably. So let's start with the clinical discussion. This patient whom I had operated was a 68-year-old male of a primary open-angle glaucoma. On maximal therapy, the pressures were 28, and that's when I decided to do a right-eye phacotrabeculectomy with mitomycin. I usually do a separate incision phacotrabeculectomy. On the first post-op day, the bleb was diffuse, the anterior chamber was deep, and pressures were what I wanted to achieve, the 10 millimeters of mercury. The patient was put on routine post-operative medications, that is prednisolone acetate and cyclopentolate. Now, whenever a patient is operated for a trab or a phacotrab, you have to it's just not the pressure you look at. You have to lift the lid. You have to look at the bleb. As Dr. Manish said, you have to look for signs of sedals also. It could happen in the immediate phase if you have a buttonhole. So whenever you check the pressure with your fluorescein, at that same time you can check for sedals too. You have to look at the appearance of the bleb. As the previous speakers have highlighted, you have to look for this vascularization, the height, the thickness of the bleb. Everything is important. So the first signs which might just start like telling you a telltale thing that there's an increase in bleb vascularization, which starts usually from the periphery, as you can see all around here. Gradually it's encroaching. Then the bleb starts getting localized. It becomes elevated, but it's getting very localized and a circumscribed appearance. And this results in a gradual rise in pressure. So as soon as your pressure starts rising, like I started with a pressure of 10, and it starts drifting away, that means there's something wrong which is happening. Okay. And this is what happened actually to that patient 2 weeks post-op. It was a light one E-nut out there and very well localized and a thick Tenon's wall, and the IOP shot to 26. I've done the gonioscopy just to look at the ostium also, which is patent out here. So what is the first thing I would like to do whenever I see these things happening, kind of about the pressure drifting away? I always take a releasable suture in all my patients. And the first thing I do is release the suture, so that immediately helps you to kind of lower the pressure, and hopefully the aqueous comes out and kind of things settle down if it's just a tight suture or a steroid response or something. The second thing, if I feel it's getting quite localized and elevated, that means we are heading towards a tenon cyst. The thing is, you do a bleb massage. So you tell the patient to look down, and around the bleb you can kind of massage it. It kind of helps in hydrodissecting the bleb and probably kind of flattens. These are mostly hypothetical situations, but sometimes it works as such. I taper my topical prednisolone and probably would go to fluoromethalone, because I would just want to rule out a steroid response partly, which is adding to the rise in pressure. And then I would start the patient on aqueous suppressants, which is one of the best modalities of treatment in encapsulated bleb. So you can start with timolol, and if there's a contraindication, you could start with dorzolamide, and closely follow up these patients on a weekly basis. So this is a releasable suture just to show you. And how do you do it on the slit lamp? You look down, and with a sterile forceps just gently pull it, and the bleb gets elevated immediately, more diffuse bleb out here. And after that, in spite of that, if the patient is basically, the pressures are not coming under control, so now the dilemma is, do we do a conservative line of treatment or do we be more aggressive? And this will be dependent on the severity of the glaucomatous damage, the level of intraocular pressure, and the response to the conservative medical treatment. So if the pressure is within tolerable range, that you could have a situation where the tenon cyst is developing but the pressures are not too high, probably you might just observe, or at the most put on a single medical therapy, and digital massage might just help. So the initial approach is you reinitiate medical therapy. It's like treating the primary open-angle glaucoma step by step, add one drop at a time. Okay, reduce your steroids, mostly the powerful steroids. You could go for more of surface steroids like fluoromethalone and digital massage. Now the outcomes usually, most of the times, the intraocular pressure often decreases. It stabilizes gradually over the next 3 months and remains sufficiently reduced to avoid any further surgical intervention. And they've seen that a success rate of almost 70 to 90% with just medical line of management has been achieved. But 50 to 60% of these patients still require lifelong medication. So you might have done a trap, but they are not off medications. Almost 50% require continuous medical therapy to maintain the target pressure. And this is just to show you the success rate which have been described. It varies from anything about 50 to 100%. That means almost all patients were treated medically and they could achieve the intraocular pressure control. Now, if the conservative management fails, or if the pressures are highly or dangerously elevated, that's when you might have to think about a surgical intervention. And the surgical interventions are either needling, as Dr. Kaushik has shown us, or ultimately excising the bleb. That's if the cyst wall is too thick and you tried needling and it's just not, it's recurring, that's when you might have to do it. The needling, as she mentioned, I too perform it in the operation theatre under local anesthesia, not topical anesthesia. To reduce the bleeding incidence, you can use phenylephrine drosin prior to taking up the patient, so the vasoconstriction reduces the bleeding. I always use a 25 gauge needle. It's a longer needle, so I can go a bit more away from the central area, and it's a bit thicker needle, so it gives me a more cutting advantage as compared to a 26 needle. And you could do multiple punctures, or you could do more of a slicing effect, where you actually cut those layers of the tenons. Now, in this case, you need not be too aggressive by going under the scleral flap and into the internal ostium, as you have to do that when you have a complete bleb failure. But in this, you are restricting yourself to the superficial area on the subconjunctival space, and hence less chances of bleeding or lens touch or iris touch as such. Now, surgical excision of cyst should be considered as the last resort when there is vision-threatening visual field loss, uncontrolled IOP, and the patient has not responded at all. But there is a risk of post-operative hypotony, and the tenon cyst can still occur. I have no experience with surgical excision of the cyst. Luckily, I've never had to, but this is what I've seen from Dr. Mandal's article, where this is a tenon splegette, and you cut the conjunctiva at the same site where you have taken your previous incision, undermine the conjunctiva, and identify the cyst, apply the the mitomycin pledgette all around, and then you cut it, and this is what the tenon cyst looks like as such. Now, invariably, most of the times, in spite of medical treatment or needling, the bleb tends to flatten and kind of fails, goes into kind of a late bleb failure. And that's when you might reconsider doing a late needling, or if you feel no, it's not possible, you do a retrabeculectomy with mitomycin again, and rarely you might have to do a Ahmed valve. Bleb encapsulation can occur with any other procedure too, and this is my personal experience with patient of Ahmed valve which I had inserted. Patient had undergone a complete band buckle for his retinal detachment, and I had to put in an Ahmed valve. The patient did well for 2 months, and 2 months later, as you can see the exact boundary of the Ahmed valve. Usually you have a bleb out there and you can't see the boundary. This is like it's hugging the Ahmed valve. So this was a thick tenons which encroached the entire valve, and the bleb failed. And I tried flushing this tube out there, and in spite of that, it opened temporarily on table, but the next day again it flattened and the pressures were high. And ultimately I had to open up this conjunctiva, go to the tenons, cut the tenons, and ultimately there was a tenonectomy which was done, and we could achieve a good bleb as such. So just to long-term prognosis is relatively good. It basically represents a high bleb phase in the early post-operative period. It is self-limiting and usually self-resolving, and hence conservative approach is usually recommended. Thank you.
Thank you, Sunil.